All right, let's get started. Welcome, everyone, and thank you for joining. I am Abigail Dalton, an operations officer at the World Bank and a former member of the bank's Mind, Behavior, and Development Unit, which is the World Bank Behavioral Science team. We have a great lineup of colleagues who are going to be sharing their work with us today. If you're here, you don't need to be convinced of the importance of behavioral science for influencing decision-making and habit formation. I think you know it's a valuable and cost-effective tool to complement traditional approaches in NCD prevention, detection, and management. Behavioral science has long been a critical tool in improving public health, and in the wake of the pandemic, there's been a growing realization of its importance. You may be aware of the great news that in May, all the member states of the World Health Assembly adopted the Behavioral Sciences for Better Health resolution as recommended by the WHO Executive Board, which I think is a strong demonstration of the importance of this field for health worldwide. We're really mainstreaming. So I think this session will be particularly useful in the wake of all the enthusiasm that we have there. And finally, I just wanted to share that with the WHO, the World Bank is finalizing a third volume in our series on behavioral science around the world, examining how governments globally implement behavioral science for health at the state and federal level. This publication will have a lot of useful insights, I think, for those of you looking to build your own behavioral science capacity for health, and we're looking forward to sharing it with you. We'll get started in just a minute. A few ground rules. Please paste questions in the Q&A box. So you'll see there's two options, chat and Q&A. Questions go in the Q&A box. I always like to say questions end with a question mark, although if you have comments, we're always happy to see those as well. I'm going to go ahead and introduce our great speakers today. We have Carlos Riumalo from Erasmus University in Rotterdam, Ana Maria Rojas from the World Bank Mind, Behavior, and Development Unit, Damien DeValk from the World Bank, and Tina Licky from the World Health Organization. So I'm going to go ahead and kick it off and turn it over to Carlos if you want to turn on your camera and start sharing your screen.
Thank you, Abigail. I'm starting to share. You should hopefully be seeing again my screen, and everything should be fine there. So welcome everyone. My name is Carlos Riumalo, and I'm going to be presenting this work on where we have developed a framework to understand the behavioral dimensions for healthy longevity. This is work with some other colleagues, including Ana Maria Rojas that is here. And I won't be able to do full justice to the whole framework that we've developed and the time that we have, but I hope that I'll be able to kind of provide the importance about the framework and give you the important highlights about this. So if you're here, you're all aware that the process of making decisions is quite complex, and it's influenced by many factors, whether it's other people around us, as well as how we think, or how we do some mental constructs. So this is not less important when it comes to thinking about NCDs and healthy aging. And this is particularly challenging because the onset of NCDs and the consequences of them actually occur far in the future. So NCDs that might occur in 20 or 30 years from now are actually in formation or in development as we speak. And this makes it challenging because the incidence of the NCD is therefore a bit weakly linked to what individuals decide on the moment. And we're aware that there are many behavioral biases that make people less likely to kind of go seek treatment or go for screening because they either underweight the long-term consequences, they don't have a full grasp about the probabilities of suffering from NCDs, or they focus on very concrete consequences on the right now and sort of disregard what are diffuse outcomes in the future. So when we're thinking about healthy aging and NCDs in particular, this creates a very challenging environment to make decision-making. And in order to address those challenges, as policymakers, we need to be aware of how these are formed, how these behaviors and decisions are taken. So our objective with this project was to try to develop a framework in which we identified the processes that led these decisions. And we tried to identify different stages of healthy aging, as well as different levels at which these points occur. So now on screen, you'll be able to see a bit the big picture of this framework. And you can see these two dimensions. On the horizontal side, you can see the three stages of what we call healthy aging. So for any type of non-communicable disease, you'll have a stage where there's the formation of the disease, there's a stage where hopefully we detect the disease, and eventually there's the management of the disease. all these three combined inappropriately could eventually lead to healthy aging. And we can see that in order to take these roles on each of these dimensions, there's different levels that come into play. There's aspects that happen at the health system, others that happen at the community level, and also decisions that take place at the individual level. So if I take you through several of these rows and columns, we can think about the formation, about the habits we develop, or healthy eating, exercising, that eventually can lead to the development of a non-communicable diseases like hypertension or diabetes or so forth. And we can see that the health system can influence the formation of this by the choice architecture that is embedded in it. We can continue stepping forward to the right and see that when it comes to detection, there are physician biases that can interplay in here and how things are detected and when things are detected. And farther to the right, we can see that the provider incentives or also the physician bias can alter the management. We can go through the same example with the other dimensions, but I thought it would be more practical for us to actually look at a specific case and think about the case of hypertension. So hypertension is when the blood pressure is at a higher level, and this leads to a deformation of the blood vessels. And we can see that at all these stages, there are aspects that influence the development of hypertension, like, for example, diet or exercise. But we can see that at each stage, we can identify behavioral components that can modify or alter the appropriate pathway. So if we look at the health system again, when it comes to the formation, there might be an inattention from the health system to the possible causes of high blood pressure. When it comes to detection, physicians might have certain biases about who's at risk and therefore do some risk profiling that is not in the best interest of an individual. And if we go forward to management, there's also these issues of lack of tracking or system frictions. Community aspects are also quite important because at the formation stage, there are different mental models or norms that can relate to things like nutrition or exercise that can alter the formation. I always pick on this, but if the average size of a dish in the US is 3 times the size of a dish in the rest of the world, that is a community norm that can influence the incidence of hypertension. But the same happens with detection or management. If there are peer effects related to care seeking or screenings or peer effects related to the taking up of management drugs, that can also affect how healthy aging takes place. And at the individual level, I think this is the most salient for everyone here. It's quite easy that at the formation, there's a lot of behavioral biases that influence diet, exercise, or whether we do those, but also how we avoid going to detection, whether we want to avoid the bad news of having a disease or not, and also then the habit formation, how biases influence whether we take medication on a daily basis. So I'm now going to add with focusing in. So for each of these cases in the framework, we can then zoom in and focus in on the particular biases that can drive certain behaviors. And I'm going to now focus on the formation at the individual level. And here we identify 4 factors that can go influence the decision. One is information, motivation, and I'm going to show briefly in a couple of seconds opportunities and capacities. We'll see that in each of these factors and in the framework, we present that there are barriers that will influence the actual behavior. So if you have lack of information or knowledge or awareness, then your beliefs or preferences or aspirations concerning certain behaviors might be different. If I don't know that I should eat healthy, then my beliefs or preferences can lead me to eat unhealthy. Similarly, in terms of motivation, we know about things like present bias, overconfidence, or loss aversion, which might impede the right self-control that we have to carry on these healthy habits. And finally, if I talk about opportunities and capabilities, we can think about aspects like anchoring, cognitive decision fatigue, that can influence our self-control beliefs and whether we do these bad habits that lead to an NCD habit formation. So in these brief presentation, I've just wanted to give you an idea of what this framework is and how we've tried to identify these 2 levels, the 2 dimensions where we have to identify behavioral biases. So most of the research now often focuses just on the individual factors, but one of the things we wanted to make salient with this framework is that there are also biases at the community level and at the health system level that we also need to take into account in order to achieve healthy aging. Thank you very much. That was all from me.
Great. Thank you, Carlos. Ana Maria and Damien, let's turn to you once Carlos is able to stop sharing his screen and turns his camera off. Great. Thank you.
Yeah, me.
Ana Maria, we see presentation mode. I don't know if you want to switch it.
Yeah. Just let me try to do something.
Great.
Yep, great. Okay, thank you, Abby, and thank you to our UN colleagues for inviting us to this session. I'm here to present the findings, the early findings of a behavioral campaign to increase awareness about NCDs in Yemen that we implemented in collaboration with WHO Yemen. Really quickly, perhaps you know us, but I just wanted to say, like, I'm Ana Maria Rojas, part of the Mind, Behavior and Development Unit at the World Bank. And basically, we apply behavioral sciences to a wide range of policy challenges. We try to integrate behavioral science to development policy and generate capacity in World Bank operations with governments and partners at scale. And we have work and experiences, knowledge in different, with different activities. We run behavioral diagnostics, some behavioral interventions, run evaluations. We also conduct capacity building exercises and create these public goods throughout the world. So this is just one of the examples or the works that we did recently in Yemen. We were supporting the work that WHO Yemen was doing to increase awareness about NCDs. This work was also in collaboration with the Health, Nutrition and Population Practice at the World Bank and funded by FCDO. So what I'm gonna show you quickly today. First, a little bit of background of why behavioral sciences for NCDs in Yemen, a bit of the activities that we did, and the communication materials that we created, and then the evaluation that we are trying to do still, but the early findings from an A/B testing exercise. So, I'm not going to go into detail, but the ongoing conflict in Yemen has resulted in the disruption of Yemen's health system. People are experiencing restricted access to both facilities and medical supplies. And one of the areas of underinvestment includes the prevention and early intervention to reduce the risk of NCDs, particularly at the community level and primary healthcare levels. So, in Yemen, there is not enough data, but from limited data, we suggested that there is a high burden of NCDs-related deaths in Yemen, and there is low coverage of NCD care. And not a lot of actions have been really taken. So the WHO, together with the Yemen Ministry of Public Health and Population, embarked, funded by the World Bank, embarked in this project called the Yemen Emergency Human Capital Project, which is also a partnership with the UNICEF, UNOPS, etc. And the idea was to prioritize, to educate communities about NCDs, related risk factors and protection measures. So what was the actual project? So to best engage with Yemen citizens in preventing NCDs, the World Bank's Mind, Behavior and Development Unit helped or supported WHO in developing a social and behavioral change communication which try to integrate some of the behavioral science insights that I mean, the framework that Carlos just presented, but also with the aim of increasing the effectiveness and efficiency of this activity. So I'm not going to go on why we used, why was it relevant to use behavioral science in the context of NCDs, because Carlos just explained it. But basically what we did with who we first started with the capacity building activities with WHO, where we basically held trainings on NCDs and behavioral sciences, social norms and evaluation frameworks, and developed this guide book that is available for everyone to design behavioral informed communications campaigns. And in parallel, what we also did was to try to improve the data collection and evaluation framework that the efforts that WHO Yemen was doing and support the diagnostic and data collection activities of the baseline of knowledge, beliefs, and behaviors around NCDs. And then we ran an A/B testing exercise on Facebook to learn what kind of communication would work best. And finally, we're in the process of collecting the endline. And so let me tell you a little bit of what we found in the data collection exercise. Basically, we sample 1,800 people, face-to-face interviews. The exercise was only done in the southern and eastern governorates. We unfortunately weren't able to go to the northern governorates, but basically what the objective of this data collection effort was to understand knowledge, attitudes, and beliefs, and a little bit of behaviors on NCDs. What we found, which it was a bit surprising, but it's not completely surprising, is that Yemenis are aware of risk factors. They know a little bit less about sugar, which they use a lot of sugar, but in terms of like tobacco risks, cat exercise, they are kind of aware of this. However, what we realized when we went deeper into some of the questions was that even though they are aware of these challenges, of the problems of NCDs, they also don't necessarily act on them. So they say that 45% of the respondents believe that Yemenis consume too much animal fat. 51% reported to always adding salt and sugar to cooking. So they, even though they know they have the information, they seem to be aware. They don't really act on it. And when we went into the details, I'm not gonna go, we don't have enough time to see the details of the survey. Basically, even though they seem to know, when we asked them like they could do, they didn't know how to do it. So this is for diets and physical activity, and also we ask questions about cat consumption. And again, they think that something that was very interesting was to hear that the sessions, the cat sessions, for example, last between 5 and 6 years, 6 hours. Sorry. One of the things that I wanted to say is that I don't know if you know what cat is, but cat is this leaf that Yemenis chew, and they spend very long hours chewing it. So it's one of the things that we wanted to address in this campaign. So also, because this is relevant for our intervention, most of the medical information that the Yemenis receive is coming from friends and family. And also relevant for the intervention was the communication channels that Yemenis use. We know that social media is used mostly by men, even WhatsApp. And we also know that the TV channel that Yemenis use the most. Why is this relevant? Because basically we design a multi-format communication campaign. We develop different materials for several formats. The first one was a talk show. The second one was a radio. Then we also developed infographics that were disseminated on social media, and also SMSs. that were sent. So what was sent? We focused on 4 risky behaviors. We applied behavioral sciences on consumption of salt and sugar, physical inactivity, cat use, and cigarette consumption. And throughout the activities that I'm about to show you, those were the things that we tried to co-create and inform with the WHO. So the first activity, the communication material that would help inform with behavioral insights, was a talk show with 15 episodes, where, that had key speakers, that had speakers from WHO, health professionals, to celebrities and influencers in Yemen, basically talking about the risk factors and healthy habits. And again, what we did was to try to use the behavioral lens to inform all of the scripts and content. This was also the case with the infographics developed. We created with the WHO 30 infographics on the 4 risk behaviors that I just mentioned, and they were posted daily on social media, on Facebook, Instagram, and Twitter. They contain all of this information about risk behaviors, but again, this was all framed in a behavioral science, had a behavioral science lens. There was also a local radio broadcast and a No Cat Ramadan social media campaign. So just to finish, we are still in the process of evaluating this. We are collecting the N-line, which in Yemen is a challenge, but we think it's a very interesting challenge, and we are learning a lot from the collection of the baseline, but also from the N-line. There's not a lot of information about NCDs in this country, but what we did was to try to do an evaluation of the infographics. We basically, what we did was, on Facebook, for 7 days, we ran an A/B testing exercise where we posted first of all, separated women and men, and then targeted an infographic for women, and then another one for men. The purple one is for women, and the yellow one is for men. And basically, what we did was to see which one would be more effective on Facebook, with the metrics of Facebook clearly. And what we found here is that the behavioral informed infographic was more effective at likes, at reach, and at impressions, mostly for men. So the difference wasn't significant for the, even though the infographic was, the behavioral informed infographic was performed better for women. It was not significantly different than the performance of the standard one. However, it was for men, it was significantly different, meaning that just little insights into an infographic can lead to better performance on something like Facebook. So as I said, right now, we're collecting the survey, the online survey, and we are very excited to show you the results hopefully soon. That's it for me. Thank you so much. And I give the floor to my colleague, Demian.
Thank you very much. I think, yeah, let me check. Let me share my screen now. Can you see this well?
Yes, you're all set.
Okay. So it's a pleasure for me to present this work about invitation, incentive, and condition, a randomized evaluation of demand-side intervention for health screenings in Armenia. It's joint work with my colleagues at the World Bank, Adana Shukuma, Nonoa Elivi-Gederesu, and Mariana Koshkakarian. I have a problem moving my my slides. Sorry about that. Can someone help me, or I will stop?
I don't think I can take control.
No. Let me share again. And
I mean, if you want, I have your slides. I could also present them for you.
Okay. I don't know if sharing now?
We can see your PowerPoint.
I think no, it works. So I don't know. There was something frozen. So I think it works.
So Damien, right now we can see a variety of slides, but not it's not in presentation mode, so we can't see.
Okay, let me try again. So what about this? Does it work?
Yes.
But I'm again frozen. Can someone please share for me?
Yes, I will.
Yeah, sorry about that.
I cannot seem to, yeah, here.
Yes, if you can go in slideshow mode.
Perfect.
Yes, okay, well, that's where we are. So if you can go to the next slide. So we start from the fact that there is a high level of under-adoption of screening, that is secondary prevention for early diagnosis of non-communicable disease in low and middle income countries. 61% of people living with hypertension in those countries are not diagnosed, and 90% is the percentage estimated failure to achieve blood pressure control among all cases. And we know that the complications include stroke, cardiovascular disease, and then mortality, including premature death. Next slide, please. So in Armenia, where this study takes place, before the intervention in 2016, there were gaps in screening uptakes that were still there. Less than 50% of people above 15 years were screened for hypertension on a yearly basis, and less than 25% in the same group were screened for diabetes annually. Next slide, please. So we conducted focus group discussion with service users in 2018 that had, with users that had not been screened in the previous years. And what we found is that there were some inaccurate perception of risk and returns. People didn't know how to schedule appointments for screening. They were uncertain about the benefits. And there was a problem with the credibility of information from mass media campaigns. So there was a need for more accurate information. There was also sensitivity to price and hassle, including the need for a repeat visit for fasting blood sugar screen for diabetes. So people didn't really know, do I need to come having fasted, etc. And issues with the need to pay out of pocket. So what we found is that it was important to find a way to reduce hassle and the price. And then there was also this problem with present bias and procrastination. People were saying, well, I've planned to visit the health facility, but I just haven't gotten it done yet. So we thought it would be good to design an intervention with time-limited incentives that would also serve as deadlines. Next slide, please. So the objective of our study was to examine the impact of incentives, invitation, and condition on screening rates for hypertension and diabetes among adults aged 35 to 68 who had not been screened in the past year. Next slide, please. So what we designed is 4 interventions. The first intervention was a personal invitation that was hand-delivered from the physician for diabetes and hypertension screening. On the right side of the screen, you see an English translation of that invitation, and that include information that screening is important. It was signed by a doctor. The information also is that screening is not time-consuming, it's painless and free. There is information about the location of the clinic, how to schedule a call, and what is the need for pre-screen preparation, including fasting. So that invitation was present in the 4 intervention group. And the intervention group 1, it was only that. Intervention group 2, it was the same invitation, plus 1 paragraph with information that peers of the same gender and age had been screening. Intervention group 3 is the same invitation, plus what we call a labeled pharmacy voucher was about $10 that was not conditional on being screened. It's just given with the invitation and says, well, that's an encouragement for you to be screened. And with this voucher, you can get goods for the value of $10 in a pharmacy. In the 4th intervention group, It was also the invitation plus the pharmacy voucher, but that time it was conditional on being screened. That is, you would receive the voucher only after it was established that you had gone for screening. Then we had also a control group where there was no personal invitation for screening or voucher, but people had been exposed to the general national campaign to increase screening for diabetes and hypertension. Next slide, please. So I'm not going to go into the detail, but it was a randomized control trial. We selected people from the eHealth database in Armenia. That's how we could identify people who were not screened for hypertension and diabetes in the previous year. We randomly allocated them to these 5 groups, the 4 intervention groups and the control group. There were some eligibility criteria, including consent and being available to be reached by phone. And then in the end, we had 2,000 participants that were randomly selected, 400 each in the 5 group that I have described, the 4 intervention group and the control group. Next slide, please. So our data source are the health clinic administrative record to assess screening attendance. And then we conducted a baseline survey to collect socio-demographic data. For the 4 intervention groups, it was done between July and September 2019. And it was just it was together with the distribution of the invitation, and in group 3, the distribution of the vouchers. And then this same survey was done in January 2020 for the control group to avoid contamination with information on screening. Next slide, please. So I'm not going to go into detail, but this is the usual table showing that we are well balanced for most variables and we control for them. So let's go to the results. Yes, this is a good slide, thank you. So from a baseline of no screening, what we find in 6 months, in the control group, comparison group, only 3.5% of people screened. In the 3 first intervention group, invitation only, invitation plus infographics about screening behaviors among peers, and invitation and the non-conditional voucher, we find that the screening rate was between 17.5 and 18.5%, so about a 15 percentage point increase compared to the comparison group. But in the group 4, which included the invitation and the voucher that was conditional on actually screening, we double that impact, and now we basically have a plus 30 percentage point increase in screening rate. So that's our main results. On the next slide, we basically transform that in a cost effectiveness estimate. Obviously, the 2 intervention group with the $10 voucher are more expensive. So what we find is that in terms of average cost per person screened, it's about a little bit more than 60% for group 1, 2, and 4, and it's double that for group 3. So remember, group 4 was more effective, but costed twice as much, more or less. So in terms of average cost, it's about the same as the first 2 groups. But the group that gave the voucher unconditionally is more costly because you basically give that voucher to everyone. Next slide, please. So a few limitations of our study. So the control group was not surveyed at baseline, but at end line. There is only 6 months between 2, and we are asked about fairly stable socio-demographic variables. We don't think there is too much. The reason we did that is that we didn't want that all the question about screening that we have in that survey would influence the participants in the control group. But we acknowledge that there might be some a combination of intervention effect and survey effect for our intervention group when we compare. And then there were some differences between intervention and control, in part due to the different timing, but we control for that in the regressions. Next slide, please. So what are the policy lessons and next steps? We find that personalized message, invitations, and financial incentive have the potential to increase screening uptake and primary healthcare use, which has historically been low in Armenia, and of course is also in many countries. Message and conditional incentive were equally cost effective, but the unconditional incentives were less cost effective because group 3 was twice as costly as group 1 and 2 because of the voucher, but equally effective. So the stronger effect was with the conditional voucher, but it was also more costly. So it's also important to note, just with the simple invitation, that simple messages were less expensive but equally cost effective as the conditional incentives. And actually, this was sort of a pilot we conducted, and then the government of Armenia decided to go with the personalized invitation that now are being sent to encourage screening in the disease prevention and control project. That is the World Bank funded project in Armenia that is trying to increase screening for hypertension and diabetes. Next slide, please.
And Damon, oh, great. I was just going to say time to wrap up.
Yes, this is just, we thank all the participants and the Ministry of Health and Media Model and our funder, and I'm done. Thank you very much.
Great. Thank you so much, Damien. And Tina. Great. And Tina, apologies since you are going to fall victim to the last presenter syndrome, but if you can aim to wrap up by about 8:50 or so, just so we can have a few minutes for questions at the end.
Yeah, for sure. Absolutely. Yes. Hi, everyone. My name is Tina Licky. I work at the Behavioural and Cultural Insights Unit at WHO Regional Office for Europe. So in terms of just the context, many of you know WHO has a headquarters in Geneva and 6 regional offices. So I sit with the regional office that's based out of Copenhagen, and we cover 53 member states. So that's well east of the EU. So that includes the Balkans, the Caucasus, and Central Asia. That's the broader context. So our definition, just to set us kind of a bit of a context of behavioral and cultural insights, our focus is very much on 2 parts. First part is the formative work to gain insights into what is actually driving individual behavior in a given context. And that entails the kind of psychological theories that colleagues have spoken about today, but it also entails really an understanding of the whole socio-political, cultural, and economic context in which people are in the health system's perspective as well. And then the second part, which obviously I think everyone here is very interested in, is how do we then translate these insights into what drives behavior into better interventions that can then be evaluated. And I will say I loved all the work presented by colleagues before me, in particular the evaluation work and cost effectiveness work. That's very much where we also see a lot of the value of this work. So very briefly, why is behavioral and cultural insights a priority for WHO? It actually hasn't been sort of kind of explicitly articulated as a priority until quite recently. So the unit at the Regional Office for Europe was set up in 2020 at the same time as the Behavioral Sciences for Health unit in headquarters. So it's a relatively new area, but I think there is very much a consensus that many of the big public health challenges of our time have human behavior at the heart of them, whether it's the person or it's the health worker's behavior oftentimes. So for us, this includes NCDs, and it is one of the big areas that we collaborate with colleagues and with national health authorities across the region. So just some key milestones before I dive into a couple of case examples. The first one is just to say that, as Abigail mentioned at the very start of this session, there was a global resolution that was adopted in May by the member states of WHO. That was actually preceded by a regional resolution and an action framework on BeSci for health by the member states in the Euro region. You can see here in this image the 5 kind of key areas or strategic commitments, ranging from building awareness and support of behavioral and cultural insights for health through to implementing strategies and plans. So this is very much kind of a live process. We're working closely with the 53 member states. They just reported on their activities to WHO. There will be a report on what is happening in the space across the region. And also we're meeting for the first time with all the member states in September to advance this agenda. So the framework that I'll be talking about in the 2 case examples is what we call the tailoring health programs. And it's very similar, I think, to the frameworks that many of you in different behavioral units are using. And it's got 4 phases, going from the situation analysis to implementation and evaluation. But what I think is quite nice about about the tailoring health programs approach is that it was developed over a decade together with national health authorities, and it's got a theory of change at the heart of it, and a theoretical model. It uses COMBI for those who are familiar, but it has this toolbook of incredibly rich both case examples and really concrete exercises that I would argue you could almost do a end-to-end behavioral science project just using those exercises with a project working group with different stakeholders nationally to take you through from problem diagnosis through prioritizing barriers to designing interventions. It's a bit lighter on evaluation, but it recognizes that it is a really important part. So yeah, sorry, the link is there, and we are yet to do an official launch, but it's now online. So I thought I would share for those who are interested. And there is an online training course that anyone can access and attend, where you can learn more. It's about 4 hours of online learning. So this is just an example of the kinds of tables and things that the toolbook has. But going into the interesting part. So first case example relates to tobacco use and cessation in North Macedonia. I don't know if many of you have been to North Macedonia, but it has the highest smoking rates in the European region. Almost half of the adult population smoke, and they smoke about a pack a day on average, which means that some people obviously smoke less and some smoke more. And WHO was approached to support the Ministry of Health to review the policy framework for this. And there was the first thing that sort of jumped out was that there wasn't really much information about what were actually the barriers and drivers among people and health workers to supporting smoking cessation. So we did 2 studies. One was a survey and one was a qualitative study with health workers. And I won't go through the methodology. You're welcome to reach out afterwards. But some of the key findings that came through, this is just to illustrate kind of how we can use the tailoring health programs approach to really unpack what is going on a given topic on NCDs. So one of the key findings that came through is that smoking is still very much a social norm. And the perceived norm was that most others also approve of it. Only 17% of the respondents said that other people would frown upon smoking or disapprove of it. There was also a sort of health workers were saying that it's a very unhelpful narrative, placing or representing the country as being a tobacco country. They produce a lot of tobacco. So that's more of a kind of policy recommendation. In the survey, we saw that people start smoking young, some even a third even before the legal smoking age of 18. Current e-cigarette and heated tobacco product use is pretty low, but the perceptions are interesting. People, especially young people, saw these as less harmful than tobacco products, which is a misperception. And interestingly, often, we think about these public health issues as being a knowledge deficit issue, right? People just we need to tell people why this is harmful. And of course, we know from behavioral science that's not the case. And we saw in the sample that 81% of those who smoke in North Macedonia think it's harmful or very harmful. However, over half of them say, I never want to quit. So clearly something's going on here. So some of the other findings that we found that maybe help unpack some of this is that people who had succeeded in quitting said, who had tried to quit said, okay, well, a price is part of the picture. However, actually, if you look at it, it is very, very affordable to smoke still in the country. So this points to the importance of increasing taxation in the country. And we did have questions on policy support for different policy measures. And this one is a bit on the fence. So about half the people, about 56% would have supported higher taxation. But that may still not be politically quite palatable. The really interesting part for me were the interviews both with health workers and the survey work around how does the health system support people to quit. And what people were saying were that 70% of the smokers who said a health worker spoke to me about quitting, they said this was really helpful in helping me to think, motivating me to quit. However, only 14% of smokers said a health worker ever talked to them about this or spoke to them about this in the past year. So there's clearly a disparity. This is a tool, but it's underused. And when we spoke to the health workers, they said, well, the issue is we can only really offer generic advice because we really feel like we don't have many tools. We can't, for example, prescribe pharmacological support for nicotine addiction because that's not covered by the National Health Insurance. And also we don't know where to refer. So there's an unclear referral pathway from the primary health care doctor to a specialist cessation center. And lots of interesting data on smoke-free environments. A lot of people still smoke inside restaurants because it's allowed in a sort of separate area, but often there's not much distinction between the smoke-free and smoking areas. A lot of, well, 12% of people still smoke inside workplaces, even though that is not allowed. And the support here was quite high for actually having a stricter ban and enforcing it more. So I'm not going to go through, with the interest of time, through all the key recommendations, but for us, these two studies really came nicely together to show some of the policy gaps, some of the lack of enforcement of some of the evidence-based tobacco policy measures. And we're taken up very well. We had a very positive response when we presented these a couple of weeks ago to national stakeholders. So of course, the next step is to look at, okay, even though these are high-level policy measures, behavioral science can still play a big role in how they get implemented. So if one of the policy measures is to strengthen the smoking ban in public places, well, how is it enforced? Who is supposed to enforce it? And how can we ensure that the incentives are aligned for them to do that enforcement? And if you look through all the recommendations, I would argue that for each one of them, there is a behavioral angle, and we can continue to work together with the more kind of policy, the bigger policy angle to ensure that these measures are effective. Abigail, I had a second example on breastfeeding from Kyrgyzstan, but I think in the interest of time, I can maybe just say that if anyone is interested in that topic, they're very welcome to reach out. It was also using the Tailoring Health Programs approach, so very similar 4 phases, also starting with formative research. But I think it would be interesting to maybe open up for discussion at this point. Thank you.
Yeah, that sounds great. Thank you, Tina. We've had a few questions come into the Q&A box, and please keep them coming if you have them. You can also feel free to raise your hand if you have a really pressing question. I'm going to select a few to get started, and then I actually have one of my own for Ana Maria and others, but I'm going to start sort of chronologically. So there was a question from Martha for Carlos, which is, where and how might you include systems beyond health that may impact NCDs, the built environment that often does not support walking or other healthier behaviors? And maybe I'll tag on to this for Ana Maria, but in the context of FCV settings, I think it's interesting to think about what are the limitations there. Again, if you have a structural environment that is maybe not as supportive, or there's a lot of other pressing needs, how do you think about this in that context? So I'll turn it over to Carlos and then Ana Maria.
Okay, so that's a good question. One of the things I didn't maybe mention very explicitly about this framework is that it is encompassed by the general social structure and other social programs that exist. We haven't been very explicit about them because we think a lot of these behavioral parts channel through things like cultural norms, through how the choice architecture is done around the surroundings of the person. So we haven't very explicitly mentioned other systems beyond the health, but we believe most of them act either through the health system and the choice architectures that are around it, or through some of the cultural norms that influence the person. So I think maybe that's a bit of a brief answer for that, or how we've been thinking about this in this framework. But I can also give the floor to Ana Maria if she has anything to add to what I've mentioned. But
thank you, Carlos. So I think this is linked to Avi's question, which is what happens when you have limitations on the environment. And this is something that we thought about a lot with our WHO colleagues, because there are, let's call it, structural barriers in Yemen for people to actually address or take action on NCDs. But so, and that was like, we are all aware of those. And what we tried to do was, and this is general for the work that Embed and the World Bank does, is just not only focus on, like, we're just providing one tool. Behavioral sciences, behavioral insights is just one tool to complement the work that the other work that other organizations do, that we do ourselves in try to address and tackle those barriers. That's like the first part of the answer. But then the second part of the answer is, yes, we were very careful and mindful of some of these restrictions. And that is why, for example, in the infographics that we created on food, better food habits, they only talk about sugar and salt, because we didn't want to talk about like, oh yes, eat more fish, for example, if people cannot really afford to buy fish. So in the process, in the co-creation process of these interventions and these communication materials, we had some of these limitations, and we worked very closely with WHO Yemen, who knows the context, to be able to tailor the intervention to what was needed.
Great, thank you. I'm jumping around a bit from the Q&A box, so I apologize. But a question on Armenia, the Armenia presentation, which I think is also maybe useful to hear from the rest of the panelists. But are you getting more information in terms of the persistence of the impact of the messages? How would you expect people to start ignoring, or would you expect people to start ignoring them in the future? And so maybe for the whole panel, if you want to speak a bit to persistence and what this looks like once the project team sort of leaves and the evaluation is over.
Yes, so for Armenia, I mean, the honest answer is that we don't know, for the simple reason that we were lucky. We finished its 6-month study in January 2020, just before COVID. And so we didn't go back to look at the long-term effects. This being said, I think many of these people were screening for the first time. So maybe just going there for the first time and seeing that it's not such a big deal, not so complicated, it's free, might be very good. And then, if you remember, just the simple invitation was cost effective. And that's what the government of Armenia has decided to do. So then maybe, even if we need to repeat it every year, sending a personalized invitation to every person above age 35 or something like that, well, you don't get the long-term effect, but it's not so costly. And, in our intervention, it was a little bit costly because it was hand-delivered, it was a small pilot, but you could imagine that a government could, send this personalized invitation at a fairly low cost and even do it every year. And if you have like a e-health database, you could see who has not screened in the last year and just send this personalized invitation to do it.
I don't know if anyone else has comments on sort of persistence and sustainability of effects.
I think maybe I can mention that, so when we were drafting this framework, one of the things we wanted to do is to actually, at the end of the framework, also discuss the policy toolkit that people could eventually use. And for that, we tried to present evidence for the different tools that one can use. And I think one of the areas where we found there was very limited evidence is really about this topic of persistence. So I'm not sure there's a clear answer yet, because I think many studies have been very short-term. I think there is something to say about the need of creating this evidence about which interventions might be more persistent. I agree with Damon that sometimes these repetitions can actually be very efficient, very cheap and very cost-effective. But there is also some evidence about saturation when it comes to SMS messages. I know in South Africa, with the case of TB, there was the fact that repeated messages after some time, there was some saturation. So I think there has to be some balance about this, but I think more evidence is needed to see about persistence and how the different tools can achieve that.
Great. I'm going to move to another question. One comment that I'll say for the panelists, I see some of you placing links in the chat, but I think the chat is actually limited just to the panelists. So maybe Johanna, when this is over, you can coordinate sharing links and materials, because I did see a lot of requests for, oh, the chat is open. Okay, never mind. So everyone can see the links in there and should be good to go. Another question for Ana Maria was from Ayush, and there was a huge chunk of women from the Yemen population that don't use social media at all. Based on your presentation, I was curious to know if a future continuation would focus on that and how, and maybe that's a question for anyone who's also thinking about social media. How do you do this in areas with low technology levels or social phone use or social media use.
Thank you to the person who asked this question, which was one of the challenges that we have when we design and develop this intervention, implemented it. Because yes, in the data collection exercise, we see that women have used less social media. So that was our starting point. We still see that some women use it and decided to implement it, but the next step with the WHO is the social media campaign was just part of it, but the next steps and other activities involve community health volunteers, also working with community health centers and volunteers and the practitioners to share some of this knowledge, so this behavioral informed knowledge. So this is the next step that we're working on, because yes, we know that we cannot reach everyone through social media, especially in the Yemen context.
Great, thank you. And for the last question, there was an anonymous question on what role can behavioral science play in changing habits for everyone, but maybe Tina, why don't we start with you, and then whoever is able to jump in the time we have, we'll finish there.
Thanks. Well, I'm not a specialist in habit formation. I think there are probably colleagues more qualified than me. I think the main thing is to understand, going back is what is it about the behavior that is based on assumption, and what is actually based on evidence. And I think that's our starting point for, doesn't matter what project we're doing, it's understanding, is it that people are not engaging in something because they can't afford it? Is it because they don't have access? Is it because there are some personal individual beliefs or biases driving it? And I think after that, you can start unpacking. And then when it comes to cementing new habits, I think there's a host of evidence ranging from things like the fresh start effect, the timing of when do you introduce a behavior, how do you enable maintenance, but I'll leave that to other colleagues. I think I would just say, as much as we love talking about behavioral science, I think just being a bit humble about where our evidence comes from and just acknowledging that problem diagnosis and that understanding of the barriers and drivers in a given cultural context is so important. Thank you.
Great. Anyone want to chime in? Damien, go ahead.
Yes, if I can go quickly. I love behavioral science, and I think there is a lot of potential. But for example, when I heard Tina, what you were saying about North Macedonia, I think here I would say just go for taxation, increase the price. I'm doing behavioral science, but I'm also an economist, and if you increase the price of cigarettes, people will smoke less. So if you ask me, the recommendation to the government of North Macedonia is just tax.
Great. I think we're officially out of time. That was a full hour of a lot of great information. I don't know if Johanna, you want to chime in with anything, but just to say, I assume that the UN team is going to be following up with recordings and presentations, and any questions that you have, you can always reach out to colleagues individually. But thank you all for joining. Hopefully you have a great rest of your day or end of your day, depending on where you're joining from. So thanks so much.